practitioner with their problem about a
Uh, yes, doctor. Is my voice audible?
لا انقطع عد.
اوكي. الحين صوتي واضح.
Yes.
Okay. So again, she initially saw EP with this problem about a week before and was prescribed antibiotics. Her symptoms initially improved but have now worsened. She has had rigors at home today and her anxious partner organized for her to come into the hospital. She has vomited once. Her previous medical history include appendectomy and an episode of pelvic inflammatory disease. She's a smoker. There is no history of diarrhea, but the patient describes some soreness in micturition and has clear vaginal discharge.
Thank you. So from the history, what do you think? Which system is involved? It is the GIT, it is the urinary system, it is the genital system, it is the respiratory system. What do you think? Where is the problem?
Urinary system.
What is in the scenario which makes you think the problem is in the urinary system?
Soreness in micturition.
Very good.
And discharge.
Very good. Okay, so you are thinking that the problem is in the urinary system. Very good. Now, anybody, not only you, anybody who thinks the problem is inflammatory or non-inflammatory?
Yes, inflammatory.
What makes you think it is inflammatory?
Doctor, excuse me.
Yeah, please.
There are someone in waiting list. Can you accept?
Sure.
The patient has fever and there is pain. There is some of the signs of inflammations.
Okay,
And
so
also
yes, patient is using antibiotics, and there is fever. There is very good. So these things they suggest that the patient is having an infective or inflammatory problem. No, anybody. So if the system is urinary and the patient is having infective problems, what findings you will look for on physical examination? In the examination, if you think the problem is infection, what will be the findings in the general physical examination if the problem is infection?
fever, chilling.
So if the
rednesses.
problem is infection, so the patient will have SIRS. This is what you mean. What are the components of SIRS?
Tachycardia, tachypnea,
Tachycardia. Tachypnea. Can you explain what is tachypnea?
the patient breathing fast.
Respiratory rate will be elevated. It should be more than 20. That is tachypnea, and the temperature will also be elevated. And if you go to the lab investigations, what you will find?
Leukocytosis.
Leukocytosis, and the C-reactive protein will also be high. This will indicate SIRS, but it will not tell me the problem is in the genital system, urinary system, GIT. Suppose if it is appendicitis, cholecystitis, diverticulitis, anything, or even pyelonephritis, cholangitis, in all those situations, patient heart rate will be high, respiratory rate will be high, temperature high. So what will tell me the problem is in the urinary system?
Organ failure sign.
In the investigations.
The organ failure, creatinine and bun.
Very good. If the creatinine is high,
Also,
urea is high, this can tell me there is something wrong with the kidney. What else?
Urine
also when I
analysis.
ask about urine analysis, I will see there may be
Urine
bacteria.
analysis. If you look into the urine, there should be an evidence for infection. What will be this evidence in the urine?
Bacteria.
Maybe pus.
Excellent. Bacteria. Bacteria are our enemies. Who is our martyr? Who will die in this fight with bacteria?
White blood cell.
White blood cell. So a living cell is known as white blood cell, but once it is dead, what do you call it?
Pus.
Pus cell. So the pus cells are our shohada, they are our martyrs. So they are present in the urine along with microorganisms which are the enemies. So now let's see what are the findings in the physical examination. So the temperature is 38.7. So this is part of SIRS. Blood pressure is normal, heart rate is normal or high?
High.
Hi.
High. There is tenderness in the right side of the abdomen and right flank. So this indicates possibility of the renal inflammation. So if usually we look it from the behind at the renal angle, but it is not specified here. The rest of the abdomen is unremarkable, and there is dullness to percussion and reduced entry in the right lower zone. So anybody, this is something special. Anybody who wants to make a comment on this line?
I guess usually if you should be tympanic.
The body will try to limit the movements of the kidney whatsoever. So the diaphragm will not move on the right side because the problem is on the right side. Because if the diaphragm moves, the liver moves, the kidney will move, and that will cause more problems. So there is a splinting of diaphragm, and that can result in collapse of the lower lobe of the lung or even the pleural effusion on the right side. So this is a kind of reactive change in the lungs. So practically this happens. Anyway, now then hemoglobin is okay. White cell count, we said now it is how much? 18.8. So it is like 19,000. As we discussed earlier, that in cholangitis, the WBC count is usually more than 18,000. Similarly, in moderate acute cholecystitis, and same is true over here in acute pyelonephritis, that the white cell count is very high. And if you come to the urine analysis, there is leukocytes, which mean the pus cells, and there is hematuria, but there is no mention of the microorganisms. But if you have a proper urine analysis, you will find the pus cells are leukocyte, and you will find the other situations. So what were our learning points in this scenario? The patient is having pain. So in the urinary system, in the kidney area, we require from you the three things. You should know about the upper UTIs. You should know about the renal cell carcinoma. We will be discussing with you in the kidney. Similarly, in the lower urinary tract, we will be discussing of the carcinoma of the urinary bladder, the prostate itself, and the urinary stones. So for the time being, let us focus over here. So in this patient, because there was high-grade fever, along with the symptoms of the infection, so we went towards the upper UTI. Now, just to remind you here that, let me open this page. Okay, can you see my screen?
Yes,
Yes.
doctor.
Okay, so just I will remind you about the patient, not from urology, who has pain in the right upper quadrant. I'm writing, I hope you will be able to see, who has jaundice and who has high grade fever with chills. What is this triad known?
Cholangitis, Charcot triad.
Charcot's triad. Very good. So this is the Charcot's triad, and this is present in acute cholangitis. And if we add to this mental confusion and hypotension, then it becomes,
Raynaud Petrad.
yes, pentate. So same is true now for the acute. So for cholangitis, just to remind you before I go ahead, so this is the, like this. So normally what we have discussed, if there is a stone over here and one of the stones come over here and causes obstruction over here, so this will be filled with bile. And if the microorganisms come over here, so this is known as acute cholangitis, and the system is typically obstructed. The second possibility is that there is no stone, no obstruction, but there is ascending infection from the duodenum into the common bile duct, and this is known as ascending cholangitis. So in this patient, simply antibiotics, IV fluids, and antipyretics, that will be enough to treat ascending cholangitis. But in a patient with the obstructive cholangitis, sooner or later you need to remove this obstruction. So now if we is this point clear, but I talk about cholangitis?
Yes, doctor.
Okay, now coming to the kidney here. So this is the ureter here. And this is the bladder over here. So sometimes there is no problem, but while the patient is going to micturate, there is an increase in the intravesical pressure. To
Doctor,
overcome this, yes.
I'm afraid the screen is not changing. We're still on the right upper quadrant and jaundice and high fever.
Can you see now?
No, not yet.
I will close and then I will reshare.
Appreciate it.
Okay, so I will draw again. So we were discussing that suppose I have given you the example of cholangitis. So I said cholangitis presents with high-grade fever plus chills, pain in the right upper quadrant, and the jaundice. And the jaundice will have change in the color of the urine, stool, and skin itching because it is obstructive jaundice. So, but sometimes, so this is due to stone. Second possibility is the ascending cholangitis. So is it clear now?
Yes.
Now this is the kidney and this is the ureter over here. And if you take this like this, so this is the urinary bladder over here. So sometimes if there is a stone over here, this part will get distended and now it becomes infective. So this is again acute pyelonephritis, but there is a stone present over here like stone over here. And the patient will have high-grade fever with chills as part of SIRS. He will have pain in the right or left lumbar region or upper quadrant, and he will have dark urine depending upon the obstruction if present or absent. The second possibility is that some people, while they are micturating, there will be increase in the intravesical pressure to micturate, and the urine will not only flow out, but it will also go in the ureter. This is known as vesico-ureteric reflux. So their infected urine from the urinary bladder, normally it should only come down from kidney to the bladder, but sometimes it will go back. So this one-way traffic is lost. This is known as vesico-ureteric reflux. And in these patients, and mostly the female patients and the younger patients, like the example you have read just now, this is known as the same ascending pyelonephritis. And the treatment is similarly the same. So we have ascending cholangitis, we have ascending pyelonephritis. We have obstructive cholangitis due to a stone, and similarly we have obstructed pyelonephritis due to any stone or obstruction in the passage. So both concepts are similar, both presentations are similar, and in both the WBC count will be very high, and both can easily be diagnosed by imaging. And of course, in a patient with pyelonephritis, it will require the urinary examination. Is up till this point the things clear?
Yes, doctor.
Okay, if you have any confusion, this session is just to explain the concepts. So please feel free without any hesitation to clarify your concepts. Now coming ahead, now what happens? I will give you again the example here. So if there is a cholangitis, let me draw again. So this is the liver, and in the liver, you know, there is the CBD, and then here there is portal vein, and there is hepatic artery. So if there is infection in the CBD, and this bile, if it goes reversely, what can cause it in the liver? Abscess. Similarly, if there is a portal vein territory and it comes from the inferior mesenteric vein, superior mesenteric vein, suppose there is a patient with the sigmoid diverticulitis, or there is a gangrenous appendicitis. So now this superior mesenteric vein or inferior mesenteric vein, it will have microorganisms, and these microorganisms, they will reach the liver and they can cause an abscess. So similarly in the kidney, if this pyelonephritis is not treated here, so it can cause renal abscess. There are other causes like diabetic patients with pyramidal necrosis and other things, but I'm just trying to make it as a story so that you can remember both situations with one concept. So there can be liver abscess, the renal abscess like the liver abscess, and then if this ruptures from here, it can be a perinephric abscess and then a paranephric abscess if it goes beyond Girota's fascias. So in summary, patient with pyelonephritis or renal abscess, which can be perinephric or which can be paranephric. So if it is pyelonephritis simple, antibiotics may alone be enough. But if there is a stone, you need to manage it. Similarly, for the abscess, you always drain and you need to give antibiotics. This, you can call it percutaneous nephrostomy or drainage. Or if it is less than 3 centimeters, you may just give antibiotics and it will become an antibioma. But if it is bigger one, then you may need to drain it. And sometimes the kidney does not have any function. Kidney function is lost. And we can see the function of the kidney by the GFR. That requires radioisotope scan. So in a few patients who are neglected patients, we may require nephrectomy because the kidney is just a bag of pus. So we can remove in some patients, not all patients. So we treat the abscess. So this is the summary of the approach to a patient with the renal or with upper UTI and the renal infections. Investigations, you can start with the urine examination, and then you can go for the imaging. That can be like simple ultrasound or CT or MRI depending upon the situation. Now coming to the second component, suppose if there is a stone here in the kidney, if there is a stone, so then we need to treat this stone. But the first thing, like in acute cholangitis, first thing is to stabilize the patient immediately. And once the patient is stabilized, if there is a pus over here, then we can go better for PN. And once the patient is stable, then we can make it even the removal through. So this is few words about the infection. Now I will say a few words about the stone, then I will take your questions. Now coming to the stones in the kidney, the patient will present usually with a history of pain, and most commonly it is the lumbar region. There are many descriptions of this pain, but this is most of the time if it is in the ureteric system, that is the colicky pain. But if it is in the kidney, then that is the kidney pain, the not colicky pain. So this is the kidney and this is the ureter. So if the stone is stuck at this level called PUJ level, pelvic ureteric junction, then this pain is referred to, suppose, on the right side in the right iliac fossa. This point is important because the PUJ pain is referred to the right iliac fossa due to the common nerve supply. So every patient with right iliac fossa pain must have the urine complete examination to look for any crystals or casts in the urine, RBCs. If there is crystals or casts and RBCs, that will indicate that the problem is most likely due to a stone at the level of PUJ, not acute appendicitis. So in acute appendicitis, you have seen there are two compulsory investigations. One was the CBC and other was the urine complete examination in every patient. But if the patient is a female, then she requires a pregnancy test and ultrasound, because in the female the ovarian and other problems can be there. So in female patients in acute appendicitis, we do require ultrasound anyway. So this is, but if the stone is in the mid of the ureter, then the pain will be in the groin, in the inguinal area. And if it is at this level, lower ureter, then the pain is in the scrotum or in the labia in females. So this is about the distribution of pain. Now few words about the type of stones. We have like calcium stones I will not go into calcium oxalate and phosphate difference, but simple the calcium stones which can be oxalate and phosphate. Of course, these stones are in patients with hyperparathyroidism. Then we have the triple phosphate stones are also called magnesium ammonium phosphate stone. We have the uric acid stones. We have the cysteines and thin blah blah. So regarding the calcium oxalate stones, please remember these stones, they have the spikes on them. Calcium oxalate stones. So they usually, because of these spikes, they cause injury to the urothelium and they cause hematuria, and they are painful, even very small, because of these spikes on them. They can form in acidic or alkaline urine. This is not specific. Regarding this triple phosphate as Stewart stones, so they form in alkaline urine. And they do not have spikes, so they can grow very big, and even they take the shape of the kidney. So this is the ureter. So they will fill all the system with the stone, and the stone will look like a calcified urine. So they will look like the staghorn stones are very big triple phosphate stones. So this is the struvite stone. They get very big because they do not have spikes and they form in an alkaline urine. So in the alkaline urine, what is the problem? Why the urine is alkaline? Because there are microorganisms like Proteus, like Pseudomonas, like Klebsiella, Staph aureus. So these microorganisms like Helicobacter pylori in the stomach, they produce an enzyme called urease. Urease will act on the urea, and urea will become ammonium. And this is the reason there is magnesium ammonium phosphate stone. And because these crystals are present in the urine, and they become crystallized in an alkaline urine. So this ammonia is from urea production by the different microorganisms. Sometimes you may be required to know these microorganisms. So please, if it is possible, try to remember the names. So the triple phosphate stones, they form in an alkaline urine. They may be asymptomatic. This is the reason they get very big. So we call them staghorn stones. Coming to the uric acid stones, you know the uric acid, there is a word acid. So they form in an acidic urine. And the patient is usually having gout, or you can hyperuricosuria. So there is increase in the uric acid level. So you need to measure the pH of the urine. So acidic urine, and the patient will have hyperuricemia, and the stone will be radiolucent. So you can remember the U from the uric acid stone. This is radiolucent stone. This is not visible on X-ray. Please remember, we use the word on X-ray radio opaque. If it is CT scan, we will say radio dense. If it is ultrasound, we will say hyper echoic. So please, if it is a report of ultrasound, or it is a CT scan report, or it is an X-ray report, you should know how to read and what is the meaning of radio dense or radio opaque. Shadow. Nobody will say there is a stone. Everybody will just comment there is a shadow which is, or there is an area which is radio opaque or radio dense. Nobody will say there is a stone. Yes, in the interpretation, they may give you that this is the most likely to be stone from the shape. So this is about their shape. Now coming to the patient. So suppose, okay, I think there is a scenario. Let me open the scenario. And to prepare the area, so and to take the protect measures. So all these they come in the. Can you see my this book?
Yes, doctor.
Yes.
Please, can you, Abdullah, can you read this scenario, please? Anybody can read scenarios, please.
Okay, may I, doctor?
Yeah, please go ahead.
Okay. A 33-year-old female office worker present to the emergency department complaining of severe left side abdominal pain. The pain woke her in the early hours of the morning and has persisted throughout the day. She is unable to keep still and has vomited bilious material on 5 occasions. She reports no diarrhea or rectal bleeding. Previous medical history includes appendectomy and irritable bowel syndrome. She has had a recent colonoscopy, which was normal. She takes Mebivarin for irritable bowel syndrome and multivitamins tablets. She smokes 15 cigarettes per day. On examination, she
Just,
had
thank you.
okay,
What is the chief complaint in this patient?
severe left side abdominal pain.
Excellent. And there is an association with nausea and
Yes,
vomiting.
nausea and vomiting, which is
Is
bilious.
there any other symptom in this patient?
Unable to keep still.
So this is about the pain. The pain is not letting the patient still. Patient is just moving around. So this is a feature of pain. But there is no other complaint other than pain, and there is association with nausea and vomiting. Do you think, yani, this is an infective or non-infective problem? What do you think?
I think non-infective.
Yeah, because there is no history of fever, there is no mention of SARS, and there is no local sign of inflammation in this patient. Okay, can you now read the examination?
Yes, of course. On examination, she has a temperature of 37, a blood pressure 125/88, and a pulse rate of 69. There is a marked left line tenderness, but the rest of the abdomen is non-tender. Heart sound are normal, and the chest is clear.
So the temperature is normal, respiratory rate is not given, and the heart rate or pulse rate is 96. So this is not true, but it is less than 100. But due to the pain, there is sympathetic nervous system stimulation that is causing mild tachycardia, but it is still less than 100. Now we have in the search 40s. So there is temperature, no. There is tachycardia, yes. There is mild tachycardia. Respiratory rate, we don't know. And the temperature is normal. So it doesn't look there is a surge. And if we look for TLC count, so what is the TLC count? Can somebody see? It is like near the
12.
upper level,
Yes.
12.8. So it is not too much. So it doesn't look to be a case of infection like we have seen in the last. It was about 19,000 in a patient with pyelonephritis. So in this patient, if you go to the urine examination, what you see in the urine, proteins are negative, but there is pus cell and there is hematuria. So please remember, while these stones they are present in the this part, they are rubbing against the urothelium. So rubbing or kissing against the urothelium, it can cause some inflammation. So there can be one or two pus cells. It does not mean infection. So in urology, you will find maybe there is a concept of sterile pyuria. Sterile pyuria. So sometimes you will find there are pus cells, but there is no microorganism. So please be careful that pus cells simply, if they are present, it does not mean there is infection. So in this patient, what is the likely diagnosis?
Renal colic or uterine colic.
So we are thinking about a colic due to underlying stone.
Stones.
Stone. What investigations would you like to do further? You have done the urine examination, CBC. What other investigations would you like?
CT without contrast.
CT without contrast.
CT without contrast, that will give you the best. If it is in the kidney, you can include the ultrasound, but of course, the best is the CT scan. What are the indications for admitting this patient? We will discuss this now. What is the initial management? We will discuss now. So now coming back, now suppose there is a stone of 4 millimeter. What to do? Stone of 4 millimeter in a patient.
Consult.
This is the kidney. So what we can do?
Expect the patient.
Expectant management. What do you mean by expectant management?
Giving the patient analgesia
So
and
give
fluid to resolve from itself,
excellent,
and maybe alpha blockers.
excellent. So you give these medications to the patient, suppose diclofenac sodium or any other drug allow like prazosin, and you ask the patient to drink like 2.5 liter of the fluid daily, and you send him home. So when the patient should come back, or no need?
If the pain is still persistent, the patient must come back.
Number one, because we are waiting, so we can wait like 4 hours, 4 weeks, 6 weeks. Does the stone pass? If it passes, alhamdulillah. Other thing which we are concerned is there any complications of these stones? So what can the possible complications of the stone here? If there is a stone in the CBD, what can happen?
Obstruction.
Oligo infection, obstruction, or kidney function can be compromised. So how to look for infection? Suppose the patient comes to you after 2 weeks and you want to rule out infection. What you will see? What you will
C-reaction routine, and I will look for the WBC.
excellent. You first of all in the history you will ask, do you have any fever? If he says yes, you may have suppose renal tenderness, you may have his urine examination, and in the urine examination you may find the pus cells and the microorganisms. So this is how, and if you see the CBC or C-reactive protein, they may be high. Okay, coming to the obstruction, how will you look for obstruction? Which imaging investigation will be good for follow-up to see the dilatation of the system?
Is it ultrasound?
You can do ultrasound to see if there is any problem, and then what to see, how to look for function of the kidney.
GFR.
Yes, EGFR.
EGFR. So GFR we are calculating with the help of isotope scan, which is a kind of radiological examination, like HIDA scan in the kidney, in the gallbladder, or isotope scan, and now we have a creatinine and patient weight and height. So there is a system that will calculate. So these things have to be seen in the expected management, and if there is anything wrong, one needs to intervene early. But if the stone is suppose more than 6 millimeter, there is different in the resources. Some resources say even 10 millimeter, because some stones are like longitudinal and they may pass by their own. So I know this difference in the literature. I think Ambos has mentioned 10 millimeter. You can see this difference in the book and in the Ambos. Anyway, if there is a valid resource, we do accept the resources. Like Ambos are up to date, we will accept these scores. Medscape will also be acceptable. But please now go to Ambos, because officially we are required to go to the Ambos. Okay, now suppose there is a 1.2 centimeter stone in the kidney. Now, before I go ahead, let us check. There is a patient, he has pain in the right lumbar region, which is colicky. Patient urine is acidic. X-ray does not show any stone. No stone is visible. Which of the following is the most likely stone in this patient? Calcium oxalate, calcium phosphate, triple phosphate, uric acid.
Uric acid.
Uric acid.
Uric acid, because this stone is not visible on X-ray and the urine pH is acidic. Okay, 60 years old male has an X-ray, and that shows us a staghorn stone. This patient urine pH will be acidic or alkaline?
Alkaline.
Okay, it will be alkaline. Why it will be alkaline?
Because it's a strovate stone.
Because of the ammonia.
Because of ammonia. What is the source of ammonia?
Infection bacteria.
Urea bacteria.
So there is organism urease, the enzyme. Who produces it?
Bacteria like Proteus,
Like
Klebsiella.
Proteus, Pseudomonas, Klebsiella, and Staph. So these are urease, and they will produce ammonia, and at this alkaline pH, magnesium. So you can remember the word MAP. Magnesium, ammonium, and phosphate, they will precipitate to form this stone. Clear? So now if there is a patient and there is a 1.2 centimeter stone on CT scan in the right kidney, which of the following is the best treatment option? Suppose I say expectant management, I say extracorporeal shock wave lithotripsy, PCNL, pyelolithotomy.
Extracorporeal shockwave.
Because we are not going to do expected management for stones more than 6 millimeter. This is 1.2 centimeter, sorry, or you can say 12 millimeter. Similarly, for stones up to 1.5 centimeter, we can break them with the help of extracorporeal shock wave lithotripsy. But if the stone is say 2.5 centimeter, now the first line treatment is percutaneous nephrolithotomy. Just please remember one point. If somebody wants to remember, it will be good. So if you see the kidney, if there can be stone in the upper or in the middle calyx, and in the lower calyx. If we break this stone with the help of the shock waves, extracorporeal shock wave, so this stone will become sand. But will it go up?
No.
No.
No. So this is the reason for the lower pole stones, there is always a problem. So usually as undergraduate students, we do not ask you, but in real life, the lower pole stones, because even if you break them with the help of extracorporeal shock wave lithotripsy, but still their resolution rate is not good. So we have other treatment, but just to tell you so that you understand the effect of gravity. So this is just to highlight for you. We may not ask you, I do not want to complicate the picture, but there is the different rules and regulations for the lower pole stones. But just remember that up to 1.5 centimeter, the extracorporeal shock wave lithotripsy is good. If it is more than this big, then we go for percutaneous nephrolithotomy. So suppose the stone is over here, and if it is 1.2 centimeter, I will go for extracorporeal shock wave lithotripsy. But if it is 1.7, I will go for PCNL. Now just one point here, if it is 1.2 and I go for extracorporeal shock wave lithotripsy, then the complications of this are infection. Because once the stone will be broken, the microorganisms inside the stone will be released. So I need to give the patient antibiotics before I break it. Similarly, patient will have pain, so I will give the painkillers. There will be painkiller and antibiotic and IV fluid should be given. If the patient is already using aspirin or there is hematuria, so this should not receive the extracorporeal shock wave lithotripsy. Similarly, pregnant women should also not receive the shock wave lithotripsy because it can cause problems with the uterus. Coming to if there is infection over here like pyelonephritis and there is a pus formation, then one option is to pass a DJ stent from here, and the other option is PCNL. And so usually if there is a stone here with pus formation, then we do not go for extracorporeal shock wave lithotripsy even if it is small. Then we go for PCNL. Is this point clear? This is an exception, because if you go for extracorporeal shock wave lithotripsy with infection, the pus is thick and it will not be drained through the ureter. So this is the reason in such patients we go for PCNL. So what you need to remember, number one, stones up to 1.5 centimeter, the less than less than up to 5 millimeter weight, 15 millimeter extracorporeal shock wave lithotripsy. If they are more than 1.5 centimeter, PCNL. But if it is less than 1.5 centimeter with pus formation, then go for PCNL. So this is about the stones. Any question up till now?
Yes, doctor.
Go ahead, please.
Yeah, doctor, just one question. What is the difference between BCN and BCNL?
So if you allow me, I can just remind you, in the liver, you are having a hydrated cyst. And the treatment is you pass a needle over here. This is called PAIR. PAIR means you go for percutaneous
Drainage, yeah.
drainage, you aspirate, you instill a cholesterol agent, you re-aspirate. And if you leave a drain, you call it PAIR PD. This is the kidney, this is the ureter, and it is the dilated kidney. Now, if you go through this, and you simply go in the kidney and you remove the pus. This is known as same. It is PC like pear, but we call it PCN, percutaneous nephrectomy. There is a gallbladder over here. If you pass a needle or a drain in the gallbladder, you call it percutaneous cholecystostomy. So it is the same. Draining the pus is known as percutaneous nephrostomy, mean removing the pus through a tube and keeping it there. But if you remove the stone from here, then you call it PCNL. L is for lithotripsy. So if you remove the stone or lithotomy, so you can do lithotripsy and remove the stone, or you can directly remove the stone. Then so L stands for lithotomy, percutaneous lithotomy. If it is very big stone, then you first break it and then you remove it. So this L is for lithotomy and N is for nephrostomy. Is it clear?
Yes, now clear. Thanks.
Okay, just last few words I will, because I know you people are busy since morning. Let me share with you one scenario from our book. Stop sharing. Okay, so let me see. I will request all of you to please have a look on these scenarios, because these scenarios are very good in understanding the concept. Can somebody read this scenario, please? Case
Yes.
61.
A 61 years old male presented to his GP complaining of intermittent left-sided leon pain for 2 months. An ultrasound scan for the urinary tract was recognized, which showed a large central mass in the left kidney. His previous medical history include recent diagnosis of hypertension, hypothyroidism, and non-insulin dependent diabetes mellitus. He currently takes thyroxine 100 milligram, uh, bendof- bendofuside, and metformin. He lives alone and drink 5 to 10 units of alcohol per week. He is lifelong smoker.
Okay, thank you. So you have seen that in this patient, the age is 61. So we discussed, whenever you see an older age patient, you always think about
Malignancy.
malignancy. Other in this patient, there is a left-sided loin pain, but like in the hospital, one patient today, I think the girls they presented, that was having an incidental finding. So nowadays, most of the tumors they are diagnosed for the kidney as an incidental finding. Patient was having some trauma. They have some scanning, imaging, and that showed a renal mass. Like in this patient, there is an ultrasound scan that showed a large central mass in the left kidney. So patient may have no symptoms at all, or patient may have a pain or hematuria or pain, hematuria, or a mass in the kidney which is palpable. So which is only like 5, 10 to 15% of the patients. So older age male, if there is a pain in the lumbar region, if there is a pain, we think about three things: either it is a stone, or there is an infection. Stone can be with or without infection, or there can be a tumor. Now, the third thing which is possible is the tumor. So, in this patient, if you have already seen the lung carcinoma. In the lung carcinoma, we have discussed the concept of paraneoplastic syndrome. Paraneoplastic syndrome is known as non-metastatic manifestations of a tumor. That is, suppose there is hypertension, suppose there is fever, suppose there is polycythemia, suppose there is liver dysfunction, anything, hypercortisolism, anything that is not due to the metastasis, that is known as paraneoplastic syndrome. So in the patient with renal mass, you need to consider this. So you can see the temperature is normal, blood pressure is high, so there is this hypertension, which can be a paraneoplastic syndrome. Pulse is normal and there is nothing else. Investigation, the urine analysis shows blood. So again, in this patient, there is a mass, there is pain, and now this is blood. So this is typical of the renal cell carcinoma, and no pus cells, proteins are negative, but there is the glucose. And there is a 3.6 centimeter mass in the left kidney. Now, uh, so, as a patient with carcinoma, what you need to understand is now what investigation is now required. What do you think?
CT with contrast.
CD with IV contrast, excellent. Can you explain the patient may have a varicocele? Why? What is varicocele?
Bad
Obstruction
report.
in the vein.
So, if we draw, this is the kidney, this is the kidney, this is the left renal vein, and this is the right renal vein. There is the inferior vena cava over here, and this is the testes over here, and the testicular vein comes directly into the left renal vein. So if there is a tumor cells in this vein, that will cause an increase in the pressure of the left testicular vein, and that will cause dilatation of the pemphiform plexus of veins here, which is known as varicocele. In general, varicocele is more common in the on the left side, but also in patients with renal cell carcinoma due to involvement of the left renal vein. Is this point clear?
Yes.
Okay, why the patient may be hypertensive?
As a part of paraneoplastic syndrome.
So you can see here they have given a paraneoplastic syndrome. So if there is a production of erythropoietin, it will cause polycythemia. If there is a renal production, it will cause kidney normally produces erythropoietin. It normally produces renin. It can cause insulin production leading to hypoglycemia. It can cause production of ACTH syndrome, ACTH substance. It can cause parathyroid hormone like substance. So it can cause the gonadotrophin. So you can see there can be hematological problems like anemia and metabolic problems. So all these are the paraneoplastic syndrome. One is known as Stoffer syndrome, not mentioned over here. That is increase in the level of AST and AST and ALT. So this can, or even the ALP may be there. So there is a liver dysfunction acute. That is known as Stoffer syndrome. So please just have a look on this. In the treatment, because the time is less, what I need from you is treatment is of course surgery. If you remember, either it is the melanoma, either it is the breast, whatsoever. So the first line treatment is always surgery. Now, in the surgery, if the disease burden is more, then we can add some systemic treatment. So you can think about the immunotherapy or other checkpoint inhibitors. So there can be tyrosine kinase inhibitors or other things. So you should know in this patient about surgery, what is the partial nephrectomy, what is the radical nephrectomy, what are the indications. So for the partial nephrectomy, when we do partial nephrectomy,
In stage 1,
anybody?
T1.
T1, if it's less than 4
T1
centimeter.
up to 4 centimeter, very good. And if this patient is unfit for surgery, then we can go for radio frequency
Ablation.
ablation. If it is a bigger tumor than 4 centimeters, some sources may give 4, and we can go for radiation. radical nephrectomy and systemic treatment, or similarly if there are METs, or you go for retrostructural. So just you should know what are the indications for partial nephrectomy, radical nephrectomy, when to go for radiofrequency ablation, and when to go for the systemic treatment. If you know this, inshallah, it will be enough for you.
The systemic treatment, the immunotherapy, we should do it in the patient who cannot, يعني, or unfit for surgery.
Yes, unfit for surgery, usually we go for radiofrequency ablation, but if the lesion is bigger, then you will have no option, because radiofrequency ablation can cure only up to 3 centimeter lesions. But if the lesion is bigger, then you will need to add the systemic treatment. Similarly, if the local burden is more, there is a residual disease, then, but my point is you just have an idea, so that you can at least you can think about a major difference. If you try to memorize, it will be rather impossible, because there are so many tumors. But just develop an idea. If it is a big disease, you cannot remove it, there is metastatic, so then you need to give, like in other tumors, then you will give the systemic treatment.
Okay, thank you.
Okay, guys, thank you very much, all of you, because it is the prayer time. So inshallah, see you tomorrow.
Thank you, Doctor.